Hello, I'm Dr. Elizabeth Coon, a movement and autonomic specialist at Mayo Clinic in Rochester, Minnesota. I'm grateful for the opportunity to be part of the MSA Coalition's Conference for Patients and Caregivers. I'm fortunate to have had the opportunity to start our MSA clinic with co-founder Dr. Laura Ree in palliative medicine and Tricia Stevens, our nurse in autonomic disorders. And much of our inspiration was from Dr. Vernino's UT Southwestern Clinic. We started the clinic after hearing what he was doing at UT Southwestern. Ours started around 2018, and we've partnered with a number of specialists, which we will talk about today as components of an MSA Center of Excellence. We will review their specific roles. So I have no disclosures. And the objectives are to describe multidisciplinary care for MSA, in addition to what Dr. Vernino said in his excellent talk, and to define the roles of different team members. So first, to describe multidisciplinary care for MSA, let's talk about the disorder. So just as the name suggests, multiple systems atrophy involves multiple systems. And as we heard earlier in this conference about how all of these symptoms and systems can be involved. We know the motor problems are very problematic, including Parkinsonism, ataxia, tremor, dystonia, and there's even more beyond that. Cognitively, patients can have memory issues, orientation issues, and kind of other things can come up as the disease progresses as well. Mood, depression, and anxiety symptoms can really affect patients' quality of life. And almost all patients have some degree of dysarthria or speaking problems. Dysphagia and stridor are prominent, as can be constipation. And a unique thing about MSA is the cold hands and feet. So as a neurologist, we even use this as a specific sign that the patient does have MSA. Now, in terms of sleep disorders, REM sleep behavior disorder is very common, as is restless leg syndrome. And the cardiovascular autonomic with orthostatic hypotension can be one of the earliest signs or may come on later. This can lead to patients passing out, which is fall risk and having injuries associated with that. And on the converse, the blood pressure can also be too high with supine hypertension. The sweating system is often involved with anhidrosis. And patients may not know that, though, because the lack of sweating sometimes is not bothersome, but it can be problematic when patients are exposed to the heat and can lead to overheating and heat stroke. As for bladder symptoms, urgency, frequency, retention, and incontinence can really strongly affect quality of life and can be really hard for caregivers as well. And sexual dysfunction is common in both men and women. But in addition to all of these symptoms, treating one of these symptoms can lead to worsening of the other. For instance, if we treat Parkinsonism with some of the best medications we have, such as levodopa or dopamine agonists, this can lead to worsening of the orthostatic hypotension or blood pressure drop. So then we recommend that patients increase fluid and salt, but then that leads to worse bladder symptoms and incontinence and even stool issues or bowel incontinence. So now patients are having multiple trips to go to the restroom with urgency, and now there's more of a risk of falls or passing out. So it is impossible to treat one of these symptoms in isolation, and that they're all occurring in one patient, and we need to keep the whole patient in mind. When we think about all of these features of MSA, though, there are multiple providers that are involved. So for motor problems, we may have a movement disorder specialist, a physiatrist, PT/OT. A physiatrist is another term for physical medicine and rehabilitation. Cognitive problems may be treated with a behavioral cognitive specialist. Psychiatrists may be involved for mood, as well as speech pathology for speech and swallowing. ENT for stridor, and a sleep specialist for the disorders I talked about earlier. And from the blood pressure issues, this may involve a cardiologist or may be an autonomic disorder specialist, depending on what's available in any area. Now, the sweating often involves an autonomic specialist, but could be a dermatologist too. urologist does the bladder, gastroenterologist does the GI symptoms, and a urologist or internist may be involved for sexual dysfunction. And in addition to all of this, so there's a lot of these different issues that have been divvied up and so many people involved, that it can be really difficult to coordinate care. And patients often say they feel like they're just going to one doctor's appointment after another. So that's where we know that, these features of MSA all are coming together in one person. Let's put the entire team together and treat one person with this disorder. And this type of model of care for a neurodegenerative disorder is something that's been done in other disorders. So for instance, amyotrophic lateral sclerosis, or ALS, has a number of different centers. They have certified centers, they have recognized centers, so different levels that are certified through the ALS Association. This is multidisciplinary care that includes a neurologist, therapist, including physical, occupational, respiratory, nurses, dietitians, speech, social workers, mental health professionals, and someone involved from the ALS Association. So there are over 200 centers or clinics that have already been established with putting the patient in one place and having the providers come to them. And what's really wonderful about this too is that there have been scientific studies to show that ALS patients in a tertiary care clinic, so this was done in Italy, had improved survival. And so the authors surmised that this was perhaps due to better implementation of the supportive treatments. But what was also interesting is that these patients had a reduced hospitalization rate. So considering that this was overall better for patients, caregivers, community in general. Now, another neurodegenerative disorder, Huntington's disease, also has centers of excellence certified through the Huntington's Disease Society of America. Now, Huntington's disease is a bit of a different neurodegenerative disorder because it's genetic. And so it has different people that are part of their team. There's neurologists, psychiatrists, social workers, counselors, and a lot of people who have experience working with families with Huntington's disease. Now there are over 55 centers in the majority of states. What is also really unique about the Huntington's disease centers of excellence is that they have a very strong research connection. So while the goal of the center is not for research, but for caring for patients, the amount of information that has been collected in studies that have done for patients who wish to be involved has led to significant enhances in the Huntington's disease field, which is kind of leaning towards better symptomatic and hopefully soon curative treatments for the disorder. So there are a lot of benefits to this multidisciplinary care. We treat the whole patient and there's integration of caregiver needs. There's better communication between team members and you're really pulling together people with expertise in MSA. However, there are some difficulties that can be encountered too. This is a really time-intensive process, and just like Dr. Bernino pointed out, this can be hard for patients and caregivers to coordinating long visit days with all the staff needed. Also, coordinating different provider schedules can be difficult, and in some institutions, this is considered cost prohibitive. But I think the benefits still definitely outweigh the difficulties when we think about how this could improve care for patients with multiple system atrophy. So the next thing I'm going to do is to introduce the roles of different team members in the MSA clinic model. So first, let's start with the clinic coordinator. So they maintain the organization and really the cohesion of this entire multidisciplinary team. They connect to patients before the visit to identify their specific needs and whether an additional or appropriate appointments are put together for that itinerary. And they maintain the updated clinical information. So the clinical coordinator is really the hub of our wheel. This clinical coordinator may come from different roles. So in our clinic, this is often our nurse working with the schedulers and the neurologist, but in other centers, this may be a social worker or someone else who has these kind of unique tools that they can use. Next, let me talk about the neurologist role. So I talked about the different problems that can happen in MSA. And as a neurologist, we put those together and try and come to the diagnosis. That can involve history, examination, doing specific imaging or autonomic testing. Often patients will have had all of that before coming to the clinic. That said, sometimes patients are referred for the diagnosis and we may question that diagnosis, and then that leads to further evaluation before anything further is done. Management is the big part of the neurologist's role, and specifically looking at the multiple symptoms and the overlap between the systems and coordinating well with multiple team members. The neurologist, as I talked about, really has the goal to make a correct diagnosis, manage symptoms. They're looking at autonomic, movement manifestations, talking about progression, and counseling. So they're really part of the leader of this model. And when our neurologist is involved, I say pretty much throughout the entire course, but especially if the diagnosis isn't certain, and then really management throughout the entire course of disease. What about physical medicine and rehabilitation? This is also called physiatry, and their goal is to maximize functional status. They can help coordinate and manage different therapists, including physical and occupational therapy, and can be really helpful for musculoskeletal complaints, including pain. Often we involve ours if there's been a change in mobility. So say patients are now having difficulty with falls, and there's a question of whether a gait aid may be useful. Would we use a specific type of cane, or would we go straight to a four-wheeled walker with a seat? Or is a wheelchair indicated? And what type of wheelchair would really be best for that patient and their caregivers? Speech pathology also plays an important role, sometimes in diagnosis, but definitely throughout the disease course. Their goal is management of deficits in speech and swallowing, and they can assist with a number of things, including vocal exercises, intelligibility. And if the intelligibility declines to the point that we need alternative communication strategies, they can be really helpful in helping to determine what would work, again, best for the patient. They are also involved in assessing swallowing function. And so there are a number of times where we involve the speech pathologist throughout the disease course. Also linked to speech pathologists is dysphagia and nutrition. Their goal is to help maintain nutrition. So their assessment and recommendations may involve this dysphagia or swallowing problems. Also kind of whether a feeding tube may be useful. This may be something that could help some patients, but others it may not go along with their wishes. So they can help with those discussions and really be invaluable. So we involve them if someone has a swallowing problem, or if there's significant weight loss, weight gain, or questions of whether a feeding tube is indicated. Otorhinolaryngology, or ENT, is also an important team member. They can help us with these vocal assessments, and especially something called stridor. So stridor is where those vocal cords don't move so well and can lead to that harsh sound. They can give diagnostic recommendations, as well as looking at the vocal cords. And in some cases with severe stridor, especially if it's occurring during the day, tracheostomy may be indicated if that's within the patient's goals of care. And then different centers, ENT physicians may do parotid injections with Botox or botulism toxin to help dry up those saliva glands if excessive salivation or sialorrhea is problematic. So we definitely get them involved. The first time that we hear that stridor is present, and in some cases for the parotid injections. Urology, also, as I mentioned, has a big role because the bladder symptoms can be so difficult for many patients. So their goal is to improve these symptoms, and they can help with the diagnosis. And so a urologist familiar with neurogenic bladder and MSA can be very beneficial. They can be important for careful assessment between different symptoms like irritative symptoms. Those are urgency and frequency, which may be better if they're treated with medications, compared to retention symptoms, which may require catheterization and get worse if they're treated with specific medications. There are different tests that can be done, like urodynamic studies or ultrasound of the bladder, to help determine between these different types of issues. And then in certain situations, they can help us initiate catheterization if that is something that the patient is interested in. And in some patients, this can really help with mobility and allow patients to leave the house, help with caregivers. Others are not as interested in catheterization, but a urologist is really important for that discussion. Urinary tract infections definitely can be an issue with catheterization and even before catheterization. So that's another time where we would closely involve a urologist. So having that urologist is really important throughout the disease course. Sleep medicine is also something that we tend to involve early on in the disease and then as needed throughout. So their goal is to assess and treat sleep disorders related to MSA. They can do a number of different assessments, including a sleep study or polysomnogram or an overnight oximetry, which just measures oxygen levels through the course of the night. It can be used as a screening tool as to whether a sleep study would be helpful. Based on those results, they may recommend things like CPAP or BiPAP. And the REM sleep behavior disorder, acting out the dreams, does have treatments that could be helpful. So we involve the sleep medicine team usually early on, sometimes to help with diagnosis. Also, if there's any report of stridor by a bed partner, then we get sleep medicine involved. Snoring or poor sleep quality would be other indicators that we need to have our sleep medicine specialists helping out. And then there's palliative medicine. So their goal is to really improve quality of life for patients with serious illness using the multidisciplinary approach. So when I introduce my palliative medicine colleagues, I say that they are a specialized team that focuses on quality of life for people who have serious or chronic medical conditions. They meet with patients and caregivers and provide an extra layer of support as you are receiving care from your other doctors. Palliative care is really supportive care. So complex symptom control, caregiver well-being, spiritual concerns, psychological issues, care planning, and end-of-life care. And so they are often really helpful early on after the diagnosis is made, because this is a big change in someone's life throughout the disease course and at the end of the life. Then if hospice is something that would be beneficial, they can be very helpful in getting that arranged. Also, as part of our palliative medicine team, we work closely with social work, also a chaplaincy, and can connect to patient and caregiver support. Now, the MSA Coalition does a fabulous job with this patient and caregiver support, and I'm really grateful for what they do for MSA. But the chaplaincy and the social work can provide additional social and spiritual support for patients who are interested, may be able to help with coping processes, support through the disease, and have local resources for patients and caregivers. So we tend to involve these team members if there's a high level of distress, especially relating to diagnosis, coping throughout the disease, and then end-of-life issues. Nursing and education is something that's been incredible in our clinic. They are integral team members to ensure education regarding this disorder. And so what we know from just studies in general is that patients really take in about less than half of what physicians say during their visits, even the best physicians. And so what we have done is that after a patient returns back home, we set up an education session with our nurses who have expertise in MSA. They provide additional education and to different levels depending on what the patient or caregiver are interested in hearing. And this is usually when patients are back home, they're doing it through kind of a Zoom type feature so that patients are usually more relaxed, and then different questions that come up and they can pass them on to different team members. Nursing and education is also really helpful if there's any changes or complications, and can be kind of the way to talk to other members in the team. So to summarize, we have talked through the multiple symptoms and systems involved in MSA that require a team approach to care. Centers of excellence are important in other neurodegenerative disorders. I think they're really crucial in MSA as well. And this coordinated care with experts with MSA experience can be really beneficial for patients, caregivers, and providers. I would really like to thank the MSA Coalition for the opportunity to talk at the Patient and Caregiver Conference this year. Thank you for Dr. Bernino for the invitation. And now I'm really excited to hear Dr. McFarland speak and hear more about this MSA Center of Excellence idea that I think could really help our patients and communities. Thank you.